All right, we're back. I know we're a little bit behind time, but that would be our last talk for today. Uh, till we come back tomorrow. Please come back tomorrow. I promise you will be a very good breakfast. The talk's gonna be amazing too, and there will be a good case presentation and discussions, and we'll leave time for questions. Meanwhile, Dr. Shakur informed me that there is a takeaway boxes. So if you like the food and you're still hungry, please feel free to take food with you home for tonight. Our next speaker is Dr. Jill Gualdoni. She's one of our most colorful intensivists. We're very excited that she's here presenting to us the role of the intensivist and the cardiogenic team, tips for the successful program and collaboration. Thank you for coming.
Thank you for having me. Okay, so I'm Jill Gualdoni. You say that like you're in the mafia, forget about it, Gualdoni. Hopefully you don't have to hear my name too much because I'm mostly a night shift worker. I'm actually on night shift right now, so we're gonna go quickly through this. A lot of the things that I'm gonna talk about have already, that's all right. They're on to me. So I did internal medicine before I went into pulmonary and critical care. And so today I'm going to be talking about the collaboration of a cardiogenic shock team and also the role of the intensivist, which to be honest, we've talked about a lot already. And so it's going to be not a super long conversation with this. I don't have any financial disclosures, no conflicts of interest. We don't get paid more if we're doing ECMO or if we're on ECMO call, anything like that. It'd be cooler if we did. So I'd like, hopefully, for us to come away from this understanding the role and qualifications of the intensivist and how they can help out, to become familiar with some of the indications for having a cardiogenic shock team, and then also what they can do, why they're important, and then appreciate some of the considerations for ECMO a little bit differently than what we talked about already. I've got some other stuff on ECMO. So first off, what is a criticalist or an intensivist? Now, these are people who specialize and they're trained in the worst case scenario of a variety of different diseases. So it's not just overwhelming infectious disease, endocrine emergencies, liver failure, uterine rupture. It is mostly going to be pulmonary respiratory failure for a variety of reasons, and then also all different types of shock. Typically, they do a residency in either internal medicine or emergency medicine prior to advanced training for adrenaline junkies. East Coast also does support a lot of anesthesia critical care programs, and then there are some programs that cater specifically to infectious disease or nephrology. And then there are about 50% of all the critical care programs which are having cardiologists go in and also do their critical care fellowship. So this is going to be a 2-year program if you do straight critical care. They specialize in all aspects of intensive care medicine, so it's not just the medical ICU, they're also cardiovascular, cardiac care. We run in fellowships, we run transplant and surgical ICUs and also do pediatrics as well. The criticalist is going to specialize in all different forms of life support. It's most particularly going to be for ventilators and then all different types of shock. If you guys ever talk to Jack Short, he calls us the resuscitation experts. But for all undifferentiated types of shock, whether they're coming from the emergency department or from the floor, the ICU is going to be the first call. So let's talk about some of the different types of shock. So first we have distributive shock. This is going to be characterized by peripheral vasodilation. So this is one where they need volume. They need to get their tank full. They don't have enough circulating. After they have enough circulating volume, then we're going to start looking at vasopressors. This is most commonly going to be like septic shock. That's what everybody thinks of when they think of shock that's not cardiogenic, but also anaphylactic, very similar pathology, and then neurogenic, when you lose that signal to tell the blood vessels to be constricted. They vasodilate. We use different medications for that. Hypovolemic shock, most commonly we think of hemorrhagic shock going under this category. This is another one where we just need to refill the tank. So with hypovolemic shock, we can also see like a lot of GI losses, like if they have like a Mallory Weiss tear or something, and they're vomiting out blood. Or here in Arizona, they could be really dehydrated, having lots of GI losses, renal losses. And then we do have things like burn victims or conditions where patients are third spacing. So severe pancreatitis, doesn't matter how much volume you give them, they're going to put it everywhere but in the vasculature. Obstructive, a little bit different than the first two. This is going to be extracardiac causes that are leading to a decreased left ventricular output. So most commonly, it's going to be like pulmonary embolisms. Also, we can see this with pulmonary hypertension when it just can't get through. Or compression of like a limb or half of the body, something like that. But it can also include cardiac tamponade because that's going to decrease your left ventricular output. And then the one that you're all interested in, cardiogenic shock. With your ability to save so many people with ischemic heart disease, we do see a lot more heart failure. So a lot of this is going to end up being acute on chronic heart failure. And then a lot of acute MIs, which is when you get that first phone call and you're down in the cath lab with them. We also have tachy and bradyarrhythmias, and then mechanical issues. So like a severe aortic insufficiency or severe MR, patients who have muscle rupture because they sat on a heart attack for 3 days because they were at the casino and that was more fun. What's that? Since the ICU is the only place that you can get pressors, shock is really our bread and butter. I just want to clarify that septic shock and cardiogenic shock look precisely nothing alike. So when we have med students who come in and we're just giving them like the basics, we say that one is hot and dry and the other one is cold and wet, cold and clammy. And we're going to look at them under ultrasound. That's one of the first things that we do when we're working up an undifferentiated shock. On ultrasound, septic shock is going to have this vasodilation, so they're going to have collapsibility of their inferior vena cava, and they're going to have a hyperdynamic heart. They're going to be tachycardic. But in cardiogenic shock, they're going to have a plump IVC. They're not going to have collapsibility even when we have them do a sniff test. And when we look at their heart, they're going to have a really diminished squeeze. And so yes, we do ultrasound and look at them before we call you. We really don't try and bother you that much, especially me, because I don't want to wake you up at 2 a.m. Nobody's happy about that. The cardiogenic shock follows a hemometabolic process or cascade, which I think we've talked a lot about already today. So in that cascade, the hemodynamic insults of systemic hypoperfusion and ischemia, and then inflammation, vasodilation, volume overload, those all result in metabolic derangements. And then we've got disease progression, which kind of culminates in potentially multi-system organ failure, which can cause death, 50% in hospital mortality a lot of times. So we're often going to see acute kidney injuries and liver failure associated with the hypoperfusion state for all different types of shock. And really that can be just a marker for severity. We use that as a prognostic indicator in our talks with the families. When you have one organ system that goes down, like let's say that they're in respiratory failure, that's associated with about a 45% in-hospital mortality. 2 organ systems, hemodynamics as well as pulmonary failure, that's going to go up to closer to 70%. You get a 3rd organ system in there, and now we're at about 70%, 80% in hospital mortality. So things escalate quickly, which is all the more reason to get an intensivist on board early, which everybody's already been talking about today, and I love that. The collegiality is great in here. Let's see it. Let's see it in the field at the middle of the night. The studies that I looked at were all looking at getting intensivists involved. They're well-versed in having these difficult conversations with the family. They're able to prognosticate based off of the different organ systems that we're seeing fail. And multiple articles also commented that we're underutilizing palliative care in these patient populations. When we were talking about Impella earlier with Dr. Prashad, he was commenting that recently it seems like everybody who we got Impella on actually ended up passing. And so palliative care can really help in discussions with the family. And in a lot of cases, they feel more that they have someone to go to and tell their fears to and really be heard and have more discussion, as opposed to sometimes we're kind of telling them that this is bad, it all looks bad, and they don't feel that they're being heard in their concerns. And we get it. Everybody is somebody's loved one, but we're really trying to make sure that they understand what they're up against. I think it's a little bit worse to get blindsided by this. Some of the articles also commented on ethics being involved as well, and I know that like Roche in particular talked about ethics a lot. So let's talk about intensivists and how the ICU can support you. One of the main things we do is POCUS, or point of care ultrasound. We do that right at bedside. We can assess cardiac function. We also use it to place lines, to move devices around, and mechanical support devices. I'm on a committee looking at implementing POCUS more so that when we have our residents in a couple months, we have a system that we can upload it to, kind of like PACS. So hopefully that will be in progress soon so that if we're doing a bedside echo, you can just pull up the image wherever you are, see what it is that we're seeing, and be like, oh yeah, this is changing, let's do something. Get that group talk started up sooner. We manage airways throughout the hospital. If you're down in the cath lab and you have somebody who is not protecting their airway or they're throwing up on the table, you're just worried about them, you can call the ICU admission phone directly. That's the 83791. You can call the charge nurse for the ICU. They'll grab the RSI box and grab us, and we'll be down there within a couple seconds. If you can't remember that, or if you're stressed out, or if the patient looks like they're about to code, just call a code blue. We're the same team. We respond to both of them. So we do run the code blues throughout the hospital. If you need us in the cath lab, we're happy to help, and that also it really frees you up to be able to focus more on the heart. We can be in the background kind of telling them what meds to push and what to do with the different drips. We can intubate the patient, and you can focus specifically on the heart and fixing the problem that's causing everything else. So a lot of collaborative effort goes a long way there. We do place a lot of central lines. We use ultrasound to do central lines for our pressors all the time. We do Cordis if patients need blood. We also place HD lines emergently throughout the hospital. We are versed in looking at indications to do emergent dialysis, and actually if you have a reason for that, you probably need to come to the ICU anyway, but we recently started leaving the ICU to place HD lines in other places in the hospital. And then swans. A lot of people come out of the cath lab with their swan, and some of us are a little bit split on this. I know back in the 80s, there were a bunch of studies looking like swans might increase mortality, and then in the early 2000s, the ESCAPE trial said no increase in mortality, but maybe some adverse events. So just talk to the intensivist. A lot of it has to do with if the nurses have a good setup at that moment when you're in the computer looking at the numbers, garbage in, garbage out. So it is just one more piece of our overall evaluation of the patient. If the clinical evaluation, physical evaluation, echo are all saying one thing, and then the numbers on the SWAN are saying something different, let's just make sure that we're all talking about it. Better patient outcomes. Then also, we will come and evaluate patients for ECMO. The whole ECMO team I'm going to talk about a little bit later. We're pretty well versed in that after a whole day of this. Let's see, the basic thing for this is really just, there's a lot of different things that fall into our wheelhouse, a lot of services that we can provide to help you guys out. Just come and talk to us. We love talking to people. I had the best experience. Dr. Mackey dropped off a patient, late in the night, like a month ago, and he called me to bedside, and we both talked about our plans for the patients and what we were going to do with the pump and what we're going to do with these drips. It was so beautiful. In my daytime sign out, I gave it to the day people. I was so happy. And then when I came back at night, Marsden was like, I had the same experience, and it was wonderful. And we're really happy about that, because that's a great learning environment too for all of the residents that are coming in, and I know you guys are going to end up with fellows pretty soon. So cardiogenic shock teams, because we want to do this with a team approach, we know that having team-based critical care is going to improve outcomes. We've seen this across the board for doing trauma teams, stroke teams, the rapid response teams for patients who are rapidly deteriorating on the floor. There are a lot of studies that show that these improve outcomes. It gets all of the specialists together in one place at the same time to make those clinical decisions, critical decisions that make a difference in the patient's outcomes. So why wouldn't we do it for shock? This has one of the highest mortalities, cardiogenic shock, despite all of the advancements that you guys have been able to make and save patients' hearts from so many other conditions. If they go into shock, we still have a really high mortality. Thank you. So the idea behind shock teams for STEMIs is actually supposed to be that we can address the sickest patients who go into cardiogenic shock because of an acute myocardial infarction. It should be complementary to the MI pathways that are already in place. And there are a couple studies that I'm going to go into that kind of talk about that. The ICU is actually an open ICU, which means if someone comes in with a STEMI, you don't necessarily have to have an intensivist on the case. You just need a hospitalist to get them into the ICU. But if something looks like it's going to start going wrong, if you're worried about their airway, if you're worried about them going into shock or having multi-system organ failure, we're going to be involved anyway. Just give us a call early. We'd love to hear from you. A lot of the articles actually talked about a shock doc, so somebody who's in the ICU managing the pressors and mechanical circulatory support kind of throughout the day, just can call everybody else up, touch base, keep all the other parties abreast of what's going on with the patient, ongoing changes. And then we talked earlier about the different team members, the cardiologist and heart failure specialist and the surgeon, and then of course sometimes the ECMO intensivist, which is different from our regular intensivists, and then perfusionists on these cases as well. So Inova Heart and Vascular Institute was one of the big names when you look at shock teams for cardiogenic resuscitation. And they published an article, which I took this quote from because I thought it was beautiful. The incidence of cardiogenic shock is rising, patient complexity is increasing, and patient survival has plateaued. So they looked at making a cardiogenic shock team where they could combine the adaptability and agility and cohesion of having one team that knew how to communicate with each other, were easy to get a hold of. Usually it's just one phone call to get multiple parties involved, evaluate the patient. That increases the disease awareness, and it allows for early multidisciplinary shock team activation. So you've got this group decision making, and then rapid initiation of mechanical circulatory support as appropriate. The intensivist can come down to the cath lab, do bedside evaluation of what's going on, really kind of help out so that you're freed up. You don't have to be thinking about that. You're just doing the catheterization. Hopefully that's improving outcomes already. But some of the studies were showing even going on mechanical circulatory support before they get their heart cath, that can help outcomes as well. So with Inova, they started this planning for the study in about 2015, 2016. And their initial outcomes in 2016, their baseline numbers for cardiogenic shock, they had a 47% survival. After only 1 year of having this project up and running, the survival went up to 57%, 2017. And then by 2018, their survival actually increased to 81% as they were more used to it. They knew who to call. They kind of had these plans in place. And then of note, their numbers for cardiogenic shock went from, I think it was 110 in 2017 to 140, and they still did better. And then, of course, these are statistically significant. They had a p-value of 0.01 for both years that they looked at. I don't think that the studies were really able to tease that out. And I mean, how would you really tell, right? So originally when they were publishing some of their baseline data, they were talking about how some of these prior studies in cardiogenic shock showing this high mortality, it's because patients who were included might be so sick they weren't ever going to survive anyway. So it's difficult to say how those changed with these studies. So I do know as their studies progressed in 2017 and 2018, they also included more young patients and then more females. So it could be that they are recognizing it in more of a patient population and improving outcomes. Absolutely. They did also find, and I'll go into this a little bit later, that they were able to activate their teams earlier, and that actually found that we had more escalation for mechanical circulatory support. So in 2021, the European Society of Cardiology Heart Failure published a review of cardiogenic shock at different centers, and they said that cardiogenic shock teams play a crucial role to evaluate the patients that may derive benefit from mechanical circulatory support, to provide more timely access for these patients, and then to prevent individual biases and identify those that may be too sick to derive any benefits. And this article actually also mentioned that we're underutilizing palliative care in these sick patients. Initiation of cardiogenic shock teams actually resulted in escalation of care and adoption of mechanical circulatory support in a lot of instances. In Canadian centers, as the first quote says, mechanical circulatory support went up to 45% from 28% in their conventional settings. And then the ANOVA group actually saw they had a 44% escalation to mechanical circulatory support. They found that every hour in delay of intensification of therapy actually showed a 10% increase in cardiogenic shock mortality. And there were improved outcomes as long as they acted within the first 5 hours. So you do still have a window. Some places were even stating that mechanical support prior to PCI was one of the main things that actually improved this. So another reason to get the whole team involved early. And then they found that support decreases the need for inotropic support, which can be a potential indicator for improved outcomes. In some studies, they actually revealed that having a shock team expedited time to mechanical circulatory support. There may be concern thinking that getting additional physicians involved, there's going to be too many cooks in the kitchen. Time or delay may actually increase. But Utah Cardiac Recovery found that cardiogenic shock teams or having a multidisciplinary team involved early actually didn't increase time to care. This is kind of an algorithm for getting everybody involved. As soon as you think that they've got cardiogenic shock, a lot of these are just coming into the emergency department, not always contacting the ICU right away. Sometimes we hear from our charge nurses that there's somebody in the cath lab on 40 of levo. Did we know about it? If we can get that team activated quickly, we can actually come down to the cath lab and be talking about mechanical circulatory support right off the bat, maybe even get that started as you're about to start your PCI. Then we can reevaluate afterwards, see if they need RV or LV support, or if they're adequately supported currently. We're going to look at cardiac power output and PAPI, as we were talking about earlier, if they need ECMO, and then all the other topics that we've gone into today. So the big thing really on this is that we have increased likelihood of mechanical circulatory support if we're getting a shock team involved early. We are escalating more quickly, we're decreasing inotropic use and improving outcomes, and we're not actually delaying time to care in this patient population. For ECMO, this is most of what we've been talking about today. In our ICU, not all of the intensivists are ECMO specialists. We have like 15 or 16 intensivists who are there all the time. We have 8 of us who specialize in ECMO. 5 of the ECMO intensivists actually are certified in cannula, and that's kind of because about a year ago when we started, there was a big turnover in the thoracic team, and so a lot of our intensivists just stepped up, started doing it. Every time that we make a decision on ECMO, as Roach mentioned, we're going to have 3 different ECMO intensivists who talk about the case, and that's largely to prevent any biases, make sure that we're considering all options. One of the strengths that our ICU team has is that we all come from so many different backgrounds. We've got a lot of ER people and a lot of internal medicine people, and we trained all over the country, and so we do things differently everywhere. We bring those pieces of medical culture together and those backgrounds and biases, so hopefully we balance each other out. We have like a Slack line that we send messages on and talk about new cases and things. So every decision that we're making is not done in a vacuum. We got a bunch of people involved. Oftentimes we have significantly more than 3 people weighing in on a case. And then we also get together regularly. We do case reviews. We talk about what went well and things that we need to improve on. We talk about things that we learned with different cases and changes that we need to make. We're going to try and make that more open so that you guys can all be there and weigh in on different discussions too. We use objective scoring systems for these. For respiratory failure, we use the RESP, right, Preserve, and I think Preset is the one that's specifically named in our bylaws. And then for cardiovascular failure, we're looking more at the SAVE score. These are all things that you can find. Yes? We do. So we always have, we've got somebody on call in the daytime, somebody on call at the nighttime. Um, we know how to get a hold of them. I don't think that they're necessarily always in the building, but if you just call the admission phone, that person, we know they can look up who's on call, wake everybody up. In the daytime, most of us are there anyway.
Tell you how to do your job, but I think we have a lot we can bring to the table and help with your patients and improve outcomes. And the two of the runs that we did fairly recently this year, we got called down to do the airway, and I'm just kind of walking down because I'm an ECMO junkie, so I love it. So I'm gonna go down with another doctor who was doing the intubation, and I'm like, hey, you guys are on 30 of levo and epi, and you have an impel in. Like, what's the next step? And they're not necessarily you guys are not necessarily thinking that because you're trying to fix the patient, trying to fix the vessels. So when I wandered down, I was like, hey, what's our next step? You know, do you need a swan to see what our numbers look like? How's your right side? And you're trying to focus on revascularization and getting, trying to get that heart back. And it's hard to think of all those things. And, your ventilator setting is dealing with the acidemia and all that. So I'm sorry, Jill, I don't mean to do that, but I just wanted to ask. I think if we can get
It's
us
a
involved,
collaborative effort.
it's collaborative. We're collaborating right now. If we can get involved earlier in the case, we can offer so much, and we don't intend to get in your way or tell you how to do your job or whatever. We just want to be there to help with better outcomes.
Yeah, that's something, sometimes somebody will come in and they are so sick, they get tubed in the field. By the time they arrive into the ER, like the STEMI role is already activated and no one gives us a heads up. And so we find out about a lot of these cases because our charge just like walks by and like, hey, I just wanted to see if you guys were aware of this patient who's on 30 of epi and they're intubated. And we're like, what? And then it's kind of difficult because like, do we just come down to your cath lab and be like, hey, what are you guys doing? Can we come in too? Like we would love to invite ourselves on, but we just want to make sure that nobody feels like we're stepping on toes because we do want to be there to support you. It's better for patient outcomes.
We're missing that earlier window to sort of improve outcomes before the organ failure, before the acidemia really sets in, and then it's really hard to unpack all that and get them back.
And we did some discussion before and some education, but obviously, like anything else in life, we need to do it over and over again so it can get, you know, engraved in all our behavior, change our behavior. So by including our ER physicians, the intensivist should be called with the cardiologist. At the moment they call the cardiologist down to the ER to assess the patient together, regardless if we're taking that patient to the cath lab or not. This is one. Two, one of the things that I found in our institution that might be a limiting factor in time is getting an echo stat. Sometimes this echo tech is half an hour away, 40 minutes away, and we're waiting to get an echo to base our decision. STEMI, it's straightforward. STEMI, you're taking them to the cath lab. Non-STEMI cases, these are where, and they're in shock, and is it cardiogenic or non-cardiogenic? So probably also if we can get your help down in the ER, go down, do the echo, since you're more proficient in getting the windows and doing the interpretation all along with the cardiologist, instead of waiting for this echo tech to come in 40 minutes and get their machine and go down. This is, we're losing 1 hour, and we know those cases, every minute counts.
Absolutely.
So that probably, we need to go back to our ER physician and try to refine a little bit more this protocol and include you again from the beginning and the point of care testing too.
Yeah, and recently we've been able to come and help and do ultrasound at the bedside when you guys need it right then, because the ultrasound tech is out and it's going to take a while. We brought somebody in and they were coding, and we had to move their Impella. Like it's easy to do those things at bedside. Like I'm not going to get as good at Windows as the ultrasound tech who does it 15 times a day, but at least we can see what we're working with.
We had several Impellas that need to be adjusted, and we can do that. We can do that for you guys too. And so you don't have to, if you're halfway across the valley at another case at a different hospital, and the patient's, something's really going wrong with the Impella, it needs to be adjusted. That's something we can offer too, to help you guys if that's would be helpful to you. I think just the as far as like the ECMO doc of the day, I think the ultimate plan is to have that person be the shock doc. I'm gonna call it that. The shock doc. I like that. Oh, you got credit. You get credit for it. Yeah. So, anyways, I'm sorry. Mechanical support at all. Like yesterday, in that case, we put a swan in. It turned out that they were just crashing and burning, and they need to go on VA ECMO. Anyways, but it's definitely influenced decision. One of the cases we had earlier in the year, the interventionalist was down there revascularizing and said, "Hey, do you need a swan?" We put the swan in. It's like, "Oh, our PAPI's like 0.5," and it's like it wasn't expected that the RV would be so severely involved, which influenced the decision of which device we were going to use. So if we're in there and there's it's like, "Hey, our Impella's not working. We're still on a lot of pressures here." It would help us to say, do we just need isolated RV support, isolated LV support, and differentiate between all those? I'm sorry if I'm stealing your thunder.
No, but you should hold that.
Yeah.
It's weird that he's like.
Yeah, I can hold it. Sorry. Actually, I'm done. Yeah.
So another. Oh.
I agree that Swan is something that we have gotten away from over the past couple of decades, and we really need to get back into it. But often, we hope that we have created a miracle by fixing the vessel and address their arrhythmias. The patients get admitted to the ICU, and we get called maybe 6, 7 hours down the road, or even the next day when we come over to see the patient, and things have gotten worse. And a swan in that case would be far more better way of monitoring those patients. And if intensivists can help us put those ends, would be actually beneficial to the patients.
Yeah, but one point I would like to bring it to the table is that there's a big gap between expertise between Chandler and Mercy Gilbert. The gap is getting wider and wider, and the patients, we are getting sicker patient in Mercy Gilbert. And there is a big kind of, you feel, when you have a Mercy Gilbert ER call, you feel a little stressed just because it's Mercy, because we know we don't have all the support which you would like, i.e. the ICU and as well as some parts in the cath lab also are missing. So is there any effort, or how do you guys schedule your duties and so on? Or is there a connection between the rotations from ICU?
Yeah, so that's difficult for multiple reasons. So the ECMO intensivist is usually going to be at Chandler because we do so many more ECMO cases over at Chandler. The people at Mercy are a little bit less versed in ECMO and Impella, but there is this issue with now that it has more maternal fetal medicine, we're seeing a lot of more sick women coming in with cardiomyopathies that might need more support. And that's a concern because if we have to take the mother, cannulate her, or put mechanical support in, and then transfer her over to Chandler, now she's at a completely different place from where her baby is. So that's something that we are working on. We have done a couple Impella cases that started there. I know there was an issue, which is hopefully resolved, but there was concern that the nurses there weren't able to take some of these cases. So that is something that we are continuously working on. We want to kind of bring the level of mercy up to where Chandler is, but honestly, Chandler is growing and changing so quickly that it's difficult to play catch up. We do all cycle through there. That's actually where I'm going to be tonight. But you're right, it's a completely different feeling. And the nurses there are very competent, very capable, but one of my most frustrating things when I'm there, I'll get a call at 2 in the morning about some issue that's actually been brewing for 4 days and no one's done anything about it. And so I'd rather be busy and work at Chandler than be stressed out over at Mercy.
Yeah. Oh, okay. So, on behalf of all the cardiologists, I know they feel the same way. It's such a breath of fresh air that you are sitting here and you are here, and that just speaks that how much committed you are. And that was not the case even a year ago. So I think you have brought some new enthusiasm and commitment to the program. And we have been, everybody has been to a place when we needed ECMO, and the people who are involved, they drag their feet so much, the patient, just a matter of time. And now you guys are saying that you call us when there's a second drip being hung, you just call us. So that's really great. We want to thank you for being so supportive for us.
Can we? I think we need to agree. Like at some point, like at what threshold are we gonna do we get a call, right? I think we all know the inflection point on the sky. Degrees according to a shot, ABCDF. There's an inflection point where we're on C, right? Where mortality really seems to take off. And I think it might be a benefit for all of us to collaborate and say, if this is a hard step. We that case yesterday, we was talking about three ECMO docs. We want to have a robust, comprehensive decision-making process. But like yesterday, that guy was, he started going south really fast. So obviously, like a lot of the formalities of the process kind of have to either get accelerated or some of them the less.
Well, you had two of you down there. I mean, if you would have called me, who am I going to be like, no.
Did we call you?
No, but had you, I wasn't going to be like, I don't think so, boys. Lyman. And that is, yeah, that is something that I wanted to talk about. So we only have 3 ECMO circuits, which means we can only run 2 cases at a time. So we got Huey, Dewey, and Louie, and if we're already using 2 of them, we can't do anymore. So we need to know in advance if you guys are going to consider if you think somebody is going to need it. So yes, ideally, we would also be called from the emergency department. We would come down with you, take a look at the patient, discuss it bedside. I think they need mechanical support. Like, they look really bad. Let's get this started, get them into the cath lab. Because there's a lot of moving pieces behind the scenes that all of our charges are working on. We need to make sure we've got an open bed in the CV section of our ICU. We need to make sure that we've got a nurse who's trained in that particular device, whether it's an Impella or ECMO. We might need a perfusionist. They've got an hour window to get into the hospital because we don't make them sit in the hospital just in case all the time. So there's a lot of things behind the scene. When we are talking about putting somebody on ECMO, we usually send out to the coordinators like a heads up, I'm evaluating somebody. That also gives the other like 3, 4, 5 doctors who do ECMO a heads up that we're going to need to be talking in the next 20 minutes. Gives us a little bit of time to gather some data. We start talking to everybody between all the conversations with what you're seeing on the table, what we're seeing in terms of lab work and outcomes. Get things set up so yeah, they can start calling people in to do this, start clearing out the rooms, making sure the nurse who's qualified to handle this doesn't have a different patient that they need to dump, get that sign out, get them ready for this patient. So ideally, yes, we would be contacted by the emergency room too. This is gonna be a new culture thing for them as well. So if you're getting a phone call to come down there and evaluate a patient, just be like, hey, give the ICU a heads up, we'll meet them at bedside, and we will be there. We would love to stand there, look over everything with you, see it fresh as it's developing, get something started. I did mention the time frames. I mentioned that we only have 2 machines. What else?
Plus, you could run one in tandems, right? You told me about that one most part, I believe. There's 2 life support. Is that accurate? So, but it's you have you don't have it.
Yeah.
That's more of a technical.
So basically, if we use a tandem circuit, that is not placed on the same limitations as your 3 machines, I believe. So we do have the option, like straight in the cath lab, because we have 2 tandem. If you needed to go on BA ECMO very quickly, you would, in a pinch, you could potentially do that and be okay.
So we need to meet with the ER, kind of help set up what the shock team is going to be, make sure that we're getting all the parties involved early. We also need to do education with other people, like in the cath lab on the way down this algorithm. You mentioned calling your friends at night to make sure that you've got a couple different people. One of the most beautiful cases that I saw, I don't even know whose case it was, but you and a couple other cardiologists were all down there talking about it. And I came down there just to help peripherally because they were coding. I actually got kicked out of the cath lab twice that night, and I know that I don't look like a doctor. I get that, but she kicked me out twice. When we came down, they called a code blue overhead, and we came down, and they're like, "We're really busy in here. Could you go away?" And it's like, "I'm your code blue team. Oh, we just need an airway. I'm your airway team." So I went to, no, I'm very colorful. Code blue. So it started off purple. Don't get me started. So just so that you can see them, when we made our bylaws, these were some of the things that we said for contraindications. We have broken all of these rules. And like Roach was saying, you know, we kind of like to break rules. We just need to have a discussion about it. We've done people over 55. We've done morbidly obese people. We've done people with different failure. Jehovah's Witnesses, same concerns everybody else brought up. If we can't give them blood, like, we could do it, but it has to be something that we think we can fix in like 2 days because they need a lot of blood usually. Um, and I think that's most of it from me. The big take-home points, this was going to be a big conversation piece because we're trying to get a lot of people involved in something new. But take-home points, really, mechanical circulatory support, it's going to require an intensivist, so why not get us involved early, particularly if you think that they're going to go into multi-system organ failure. We can help with the assessment, prognostication. Studies show that they're more likely to escalate quickly and appropriately if there's a team involved early. That it actually improves time to device, and then that has improved outcomes. So let's all play nice. Let's hang out.
Yes. And this case was actually a kind of a good example of everything we're talking about today. Is I was in the lab, we saw the inevitable bad situation, and they had the nurses just call the ICU, and they had the shock team come down there to collaborate, handle much of the things, including the SWAN, while I was handling doing the PCI and part of the decision making. One other thing that I'd like to consider is that kind of came up yesterday, but with one circuit, you have to wait for the perfusionist to come. But if you are, again, pressed for time with the tandem device, you don't. That's a purely cath lab procedure. You don't have to wait and talk with cardiothoracic surgery or anyone. You could just do that the same way you do Impella. I had one actually question for.
So she mentioned, call the number 3791, you said. Do we have it down in the cat lab? Do they know about it, the nurses? Huh? Yeah. No, actually, yes, put it like in every room that this is, like the code blue button, this is, the button for the intensivist. Yeah.
So I had one question for Dr. Gualdoni. The shock team and how they did in the, I believe it was Innova, and also here. What what members are in the shock team? Like in terms of physician, you said interdisciplinary, and also what are the roles and kind of meetings and how does that look like?
So that is something that we will develop as a group. I mean, right now, I think the first thing that we need to do is make sure that we're communicating, and we'll figure it out from there as a team, right? So all of the intensivists, we all specialize in different types of shock, including cardiogenic shock. All of us can do impellas and balloon pumps. The ECMO is the only thing that there are only certain intensivists who do. So you can talk to any one of us at any time. Certain people get super jazzed about it, like Jack Short, Chris Roach, Dr. Lyman. But yeah, it's something that we'll develop together because we're all gonna hang out and be friends and kumbaya.
Few ways we can really improve. First and foremost is, as we talked about, is the shock patients coming to the ER, and we are called. And if you guys are called simultaneously, at least we can do simultaneously evaluation at the same time, plan out the management. Uh, some of this we are talking about when they call for the shock will be most likely in stage 4 or 3. Hopefully, they will be calling us, and both of the teams from cardiac standpoint as well as intensivist will be available to do things. Uh, and it may improve the outcome, hopefully, even though if it is in stage 4 or stage D or whatever we talk. Number 2 is some of these patients generally anterior wall MI or RV infarct patients, which we are called as a STEMI. Um, I think generally we take the patient to the cath lab initially they are in stage 1 or 2, and we start doing intervention. We see that patient is tachycardic, requiring little bit inotropic support. I definitely would change in this situation, and I would, even after doing an intervention, if this is the situation, I would admit in the intensive care unit, but I will definitely call you guys because you will be seeing the patient at night time and even otherwise. And if the swan needs to be placed or anything to be done, you guys are there, you can do it, and then we can decide further um, how to go about in inotropic support for short term versus putting a device or whatever it may be. Not everyone with stage 2 or stage 3 initially, we will think in terms of mechanical support. We might just buy a time initially and see whether the revascularization has worked very well or not, depending on the presentation, of course. Number 3 is definitely we talked about is couple of cases we have looked at and we have faced is in Mercy Gilbert Hospital. I personally feel that there should be rapid transfer available from Mercy Gilbert to Chandler rather than transfer waiting for 6 hours, 10 hours. This has happened and I have lost patient. So what I'm thinking in terms of anybody who is in Mercy Gilbert Hospital with stage 2, where you see the tachycardia going on, stage 3, when you are starting to put little bit inotropic support, patient needs to be transferred to Chandler Hospital before it's too late. And I think that collaboration needs to be done. And since I think whoever is here, as far as cardiologists are concerned and whoever the intensivists are concerned, we are comfortable in doing this. At least we'll be able to collaborate with each other very well. Hopefully, that will improve the outcome overall.
This is this is why the decision has to be made promptly. For instance, if somebody is in shock and Dr. Shah is working on it, like is making a call right now. I'm in the cath lab and revascularizing the LAD. I might put a balloon pump, for instance. this patient needs to move in. It's not the idea is put the balloon pump, admit him to the ICU, let's watch for 12 hours and then make a decision. Because you're right. By the time, you make a decision and you call for transport, this is another 6, 7 hours for that patient to get from Mercy to Chandler. So these are the patient, and then even before that, you mentioned stage B, probably stage A even. I don't know. This is a decision that has to be made collectively between the administration and the nursing and the intensivist and the cardiologist. Somebody comes in with a large anterior wall MI, a large MI, a big, chunk of their anterior wall is gone. Should you initiate, and even if the blood pressure is 120 and heart rate is 80, but should you initiate the transfer at that time? Because those patients are at risk. So I don't know the answer for that particular set of patients, but our decision has to be very quick. And if we look back, this is where most of the time we lost our battles in those salvageable patients because we were a little bit slow in our thinking and in our discussion and those kind of things. Yeah. Yeah. At this point, because there is the nursing staff involved and their level, their comfort level. Years ago, what we did in the cath lab when Mercy, we're transferring every kind of high risk case to Chandler. And here the patient, an MI coming in, that we're not seeing cases. So what we did, we cross-trained the nurses. So all the nurses in the cath lab at Mercy, they were supposed to go once a week or twice a week at Chandler to be there for one day. They didn't like it, but that definitely increased the expertise level and their exposure. So yeah, I mean, those like transfer, we spoke about in one of the department meeting that's the initial phase. Ultimately, you want to make Mercy similar to Chandler, especially with the new hospital opening. But that's it's, step by step. Yeah. 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 Mm. Yeah. Mm. So probably in this, this is no, that we're going over time, but probably also in this discussion, Deval, the chair, we need to involve the transfer center in the discussion. That those kind of patients, do every effort to put them in Chandler. If they're coming from Glendale, just stop at Chandler, stop at Mercy, and initiate. Yeah, yeah. Yeah, that is, yeah, it's not,
So
yeah.
I think we have some closing remarks by George, and then afterwards we could all discuss how to do this stuff.
Yeah, all right. Well, my closing remarks are going to be short. Thank you all for coming. Again, we hope we'll see you tomorrow. I know it's Sunday and you'd rather be, somewhere else with your families. But I promise you will be great presentation, great talks. And thank you again for coming and have a nice afternoon.